to today's live. We're doing a Q&A Thursday live. We're gonna make this a regular thing. So invite Donna. Hi, Donna. How are you? Hello, my friends. Hello, everyone. Hi, hello. Welcome in. So good to see you all today. All right. So I am Dr. Nicole Smith. I am a family nurse practitioner here in Washington, Oregon State. I run a telemedicine practice here in Washington, Oregon. So here is my clinic. It's under construction. Don't you love it? You guys can see it here on the big screen. Yes. So I'm on TikTok. I'm on no, not on Instagram. Instagram, guys, if you don't follow me over on Instagram at Anti-Gravity Wellness, please do so because they won't let me go live anymore unless I have 1,000 followers. Super lame. I know. And we like Instagram, right? As a platform. It's kind of fun over there. You've got like fun little reels and stuff, and you can share things. And it's a lot easier to talk to people over on Instagram, but it's okay. You're here and I love you. And I'm so glad you're here. We're on Facebook, we're on YouTube, we're on TikTok. We are going live right now. So everybody jump on in. Here we go. Okay. So you're here in my telemedicine clinic. I practice in Washington, Oregon State, telemedicine, functional medicine, advanced hormone testing, things that we need for the perimenopausal and the menopausal woman to finally figure out what is going on. So I went through some advanced training because I myself, being a woman in her 40s, hi, welcome 40s. It's so weird. Who, ladies, and if you're watching this later, let me know in the comments, #replay. Who here is in their 40s? And who here is thinking, what the crap is this? Like, I don't feel like I'm in my 40s. I feel like I'm probably still in my 30s, maybe. I'm glad I'm not in my 20s anymore, though. Is anybody else glad that they are just not in their 20s anymore? Because that was just, oh my gosh. I don't know, maybe your 20s were awesome. That's cool for you. I actually really like being in my 40s. I think it's great. So anyways, we're going to go over some common questions and answers that I get from my practice. Let's go ahead and dive right in. Hi, everyone on TikTok. Nice to see you guys. All right. So question number 1. When does perimenopause typically start and how long does it last? So what is perimenopause? Let's start with that because a lot of people have never even heard of that. Perimenopause is the time before menopause. Menopause is defined very arbitrarily, by the way, as 12 months without a period. And that is within the correct age range. If you are like under 40 and you've had 12 months without a period, we're not necessarily saying you're menopausal unless you've had like a total hysterectomy. They took your ovaries and everything out, then yes, you are. You're in menopause, by the way. If you had that happen to you and no one told you that, and I've had patients who come to me, it was like, no one ever told me that. They're getting better about telling people, thankfully, but that's awful. You get slammed into menopause. So it is 12 months without a period. That is the transition into menopause. By the way, you don't go through menopause and then you're done with it. You are postmenopausal for the rest of your life. Every single woman will go through this if they live long enough, and hopefully you do. Every single woman goes through menopause. So we need to be talking about this. So perimenopause is that time before. When does it typically start and how long does it last? Perimenopause typically begins between the ages of 40 to 44. The average age is 47. However, we can have people go into perimenopause in their 30s. My cat's out there again. I swear to God, you do this to me. Why? She's like scratching at the door, trying to get in. She wants to be part of the live. So it can start as early as your 30s. I've talked to women who are mid 30s. I even met a girl who was in her early 30s, and she was like, "Yeah, no, I had perimenopause, and that hit early." So if you go into menopause in your 40s, it's considered early, but it's not like too early, basically. Like we can say that's still within normal. Average age of menopause is 52, but look at your family history. Who among us, raise your hand or say in the chat, who among us has a mom that had a hysterectomy? So you have no clue, and she has no idea when she went through menopause. Me. right? A lot of our moms, we're here, millennials, hello, nice to see you. A lot of us, our moms went through that time frame when like they were just surgery happy and they would take out your uterus and the ovaries for no reason. There was no cancer. Okay. There was no reason to take the ovaries. They're just like, oh, you don't need these if you don't have a uterus. So dumb. So dumb. Ugh. And so we don't have any idea because our mom doesn't even know, like when she went through, because she didn't get to have a natural menopause. So that's one way you can look at it. What did mom do? What did sister do? What did grandma do? To kind of estimate. But also there's environmental factors. We can get thrown into it early. It can be prolonged. Obesity actually makes you go into menopause later, which is not necessarily a good thing. We want to go through it when we're supposed to go through it. Okay. Yes, there's an increased risk when you go through menopause. We're going to talk about that. So, average duration of perimenopause. How long can this fun ride last? On average, 4 to 8 years. Just sucks, right? But can range from anywhere to 2 to 12 years before you actually go through menopause. Perimenopause can range on average 4 to 8 years, but can be up from anywhere from 2 to 12 years. Okay. During that time period, women can experience an average of 7 to 10 different symptoms during this transition. And by the way, it's not like, oh, I have these symptoms and we're just here and then they go away when I'm done with menopause. Absolutely not. No, it changes as we go through perimenopause. And then when we go through menopause, that doesn't mean that they just magically go away. Things like hot flashes and weight gain and low libido, dry skin, itchy ears. Did you know that was a thing? Itchy ears can be a sign of perimenopause. You have estrogen receptors in your ears. It's wild. So, I had a patient who this was really wild. So now you know the stats, right? Average age of perimenopause is 47. I had literally a 47-year-old woman come to me. And she said, yeah, I talked to my doctor, my primary care doctor, and I have all the symptoms. Like I have a list on my website. If you go to my website, antigravitywellness.com, you can take a look there. We have a list of symptoms that are very common in perimenopause. And if you have 3 or more of those, we need to talk. And she had like at least 7 of them on this list. And the doctor that she was seeing at the time, she's 47, and she was like, I think I'm in perimenopause. And they go, no, you're too young. Are you for real right now? She's literally in the middle of the average age of perimenopause. And you think she's too young? And she's got like 7 of the symptoms. Seriously, people. Okay. So there's a lack of education for sure. Absolutely. But women have a history. We have a history of not being listened to. Like we're emotional and crazy. You know what's interesting though? The studies have shown that the actual incident of things like hot flashes, even highly underreported. Women are actually underreporting their symptoms. We are not complaining. Girls, we are not speaking up. Okay. You do not need to suffer through this time period. And I absolutely demand that we do not suffer through this. It's unnecessary and it's also dangerous because if you are having things like, and I'm gonna get on a soapbox right now, I don't care. If you are having multiple hot flashes, your risk for cardiovascular disease increases even further than just the fact that you're going through menopause and then you're going to be older and our risk increases from there. If you are having hot flashes, it is inflammation in the body and it's an inflammation in the blood vessels and it's increasing your risk for heart disease. By not treating this, we are actually making the health risk worse. Okay. So it's not just something to bear. It's not just something to suck it up and get over. No, we need to be treating these things appropriately to make sure that we're controlling her symptoms, making her comfortable, improving our quality of life, and also preventing those disease processes, diabetes, heart disease, cognition issues, dementia, colon cancer. That's the thing that goes up too. and osteoporosis, softening, weakening of your bones. Okay. Next question. Let me double check the chat. Okay. Doing good. If you guys have questions, drop them in the chat. I'm trying to pay attention. It's going kind of quick. So there's a lot of people in here. And I so appreciate you all being here. Thank you. Smash that heart button if this is useful for you at all. I appreciate you being here. What percentage of women experience severe menopause symptoms? Ooh, again, we're not talking about this. People don't always know this. 75 to 80%, 75 to 85% of women experience hot flashes of some form or other. It's on a freaking spectrum. Some women, oh, I'm a little warm. Okay. Other women, multiple per day, cannot sleep, wakes them up, and it's horrible. And again, we just talked about the more hot flashes you have, the higher your risk for developing cardiovascular disease, heart disease, having a heart attack, or a stroke later on in life is, because it's literally doing damage. Every time that happens, we didn't know this before. We thought we were just controlling symptoms. We're not just controlling symptoms. We are actually helping to prevent increased risk for heart disease and for cancer. Thank you for the hearts, guys. If this is helpful, let me know. I appreciate you being here so much. Okay. 60% of women have moderate to severe menopausal symptoms. Moderate to severe, not mild. That's a lot. That's more than half. Okay. 60% have moderate to severe symptoms. 25% have symptoms severe enough to significantly impact their quality of life. I think that number, like we were talking about before, women underreport. I think it's higher than that. Especially the women that I talk to. There is very few women that I talk to who be like, I'm doing perfectly fine. I feel great through their 40s. All of us. And I same, like my numbers look great. I just did my own labs. I repeated my own Dutch test and I fixed a lot of issues that I was having. And I feel good, but I don't feel like 100% like in my 30s. Like in my early 30s, man, I could do stupid things. And my body was like, okay, that's fine. Now, if I try and do any of that, not sleep enough, maybe have a little too much to eat or drink, oh, it's awful, right? We just do not have a recovery capacity anymore, right, girls? It's awful. Okay. Thank you so much. Thank you. Oh, I appreciate you guys. Yes, had no idea symptoms were all from perimenopause. Right. Yeah. Nobody taught us this, right? Had no idea. So again, if you guys who are coming in, go to my website, antigravitywellness.com. You can see I have a list there of symptoms. If you have 3 or more of those and you're a woman over the age of 35, and if you're a guy who's older, who's having symptoms, we could talk about that too. All right. Men go through andropause, by the way. Men also have a decline in their sex hormones, but it's not as bad as women because they don't like tend to crash like we do and then roller coaster from there. Men typically just like gradually decline, but it's still a thing and they should also be treated. You guys need help too. We all do. All right. Symptoms can last an average of 7 to 9 years. Not necessarily commonly cited 2 to 3 years. Gentlemen fan club. Oh, look at my little head. TikTok is so fun. All right. So on average, 7 to 9 years, the symptoms can last through perimenopause. Okay. Thank you for the hearts, guys. Thank you so much. All right. So let's talk about hormone replacement therapy. So I get this question a lot. Here's our next question. Is HRT safe? What do the latest studies show? We still get people who come into the practice and say, oh, my doctor said I can't have hormones because grandma had breast cancer. That's not true. Or they're scared of it because they think that estrogen is going to increase their risk for breast cancer. This is a real concern. Breast cancer is still the number 2 killer of women. Heart disease is number 1, still number 1. And that one's probably going to reign forever because of lifestyle issues and things like that. But breast cancer is definitely a real concern. So not to downplay that at all. However, we now know from looking back at the WHI, the Women's Health Initiative, which is back in like 2018 or something. It was a while ago. And we know, looking at that, that when they first came out and said, oh, estrogen's dangerous, no. The women in the study were average age of like 75. Okay, that's well past menopause. They purposefully put women in that study who didn't have symptoms. And the thought process was correct. As far as like why they did that, they put women in the study who were well past menopause because they didn't want them. It was a double blind study, so they're trying to make sure that the people who were on placebo and the people who were on the medication, on the hormone replacement, didn't know that they were. And if they were symptomatic with hot flashes, well, they would know, because we know that estrogen, when that's the cause of the hot flashes, will take away the hot flashes. So they would know if they were being treated or not. So we needed to take that factor out of it to try and make it, that double blind randomized controlled trial thing, like that gold standard that we have. The problem is, and they didn't know this, and now we know this, women who are more than 10 years past menopause have probably, very likely, already developed heart disease. So when that happens, and then we give them estrogen, the estrogen makes their blood vessels nice and pliable again when they were kind of hard and stiff. So they've got plaque that's been building up inside there. But it's stiff, so it's not going anywhere. But then you add estrogen, and the estrogen makes the outside of that nice and pliable again. Then we can break loose clots. So that's where we see that increased risk of heart attacks within the first year or two for those women who are past 10 years into their menopause, and we try and restart them or start them at all. They've never had it before. Put them on estrogen. Okay. As far as the risk for breast cancer, this is really interesting. Looking back at the WHI, the Women's Health Initiative reanalysis, same study, looking at it through a better lens and really actually not like just sensationalizing the news. We see HRT, hormone replacement therapy, started within 10 years of menopause, shows a 30% reduction in heart disease. 30% reduction in heart disease. That's significant, guys. So we want to start it early, and we want to keep you on it indefinitely. There is no stop date, by the way. There's no stop date. There's no arbitrary stop date. We used to say you have to be on the lowest dose for the shortest duration. That's not true. That's not true. We get you on your dose. We're probably going to have to titrate it depending on where you're at in your perimenopause journey into menopause. And then as you age, and things can change. So you always need to follow up with your doctor. You don't just get thrown on your dose and then we'll see you later. Like, no, we need to continue to monitor these things. But there's no stop date. There's no stop date. Stay on your hormones, okay? All right, so what was it? Like 1 in 100,000 women are at risk for a blood clot, okay? And putting you on bioidentical hormones, oral estradiol, because the topical doesn't show any increased risk for blood clots, like at all. Oral estradiol can increase your risk by we'll get 2 more cases per 100,000 women of a blood clot. And it's not necessarily fatal, by the way, not fatal, just a blood clot, not fatal. Okay. Now that increase is even more. We get up to more like 6 per 100,000 for synthetic hormones. You know what's a synthetic hormone that a lot of us women were on for decades and had no idea that the actual doses of that were way higher than they are for hormone replacement when we go through perimenopause and menopause? Birth control. Birth control is a synthetic hormone, and unless you were on the progesterone, low dose progestin type form, which is, by the way, acts as an androgen or a male hormone in your body, then you were actually taking way more estrogen and a synthetic form of estrogen. And that's why with birth control, like oral tablets, those little birth control that we always used to take, right? I was on it for, I don't know, about 15 years. A lot of us were. Like, that's what you did, right? That increases your risk for a blood clot far more, far more. You know what also increases your blood clot risk far more is smoking and obesity and heavy drinking. So we need to take all of these things into account. let's not go after estrogen. All right. It's our hormone that we need, that our body needs. And we're just trying to get you back to a more, not even like your 20-year-old self. Okay. We're not trying to do that. We are just trying to get you into a therapeutic range, usually around 80 for your estradiol. If you check serum labs, we want you around 80 with symptoms controlled to prevent things like heart disease, osteoporosis, colon cancer, dementia, all of these things. Okay. So that's our goal with the estrogen. We're not trying to get you to like some super high level. It's like when we replace testosterone in women, people like freak out about it. You're not going to turn into a dude. Okay. We're not giving you like performance level testosterone. We're giving you physiologic levels back, giving you back what your body is losing for whatever reason. Okay. Thank you so much, you guys, for coming in. Smash the heart button if this is helpful at all. Let me know, guys, if this is even remotely helpful for you. Hormone replacement therapy reduces osteoporosis risk by 50 to 70%. So I'm going to tell you a story. Until very recently, I'm now in this practice full time, but I spent the past 5-ish years as a nurse practitioner working in the hospital setting as an hospitalist specializing in orthopedics. So what that means is that I took care of like hip fracture patients and total joint replacement patients. And those were the people that I helped with. I helped the surgeon to manage their care and take care of their medical things and, their all of their medications they came in with. A lot of these people are older, so they got multiple, call them comorbidities, other illnesses that they're dealing with that are chronic, and all these medications. So I helped them manage all of that so the surgeon could just focus on the orthopedic side of things and their surgery. So I met a lot of people who came in for hip fracture. Hip fracture is very significant. It's a late sign of osteoporosis. There can be some other underlying causes, but one of the most common causes for a hip fracture is osteoporosis. Men and women can both have hip fractures. Women are at higher risk because after menopause, as we lose our estrogen, that estrogen was helping rebuild our bones. So our bones are our bank. Our bones are our bank. So we're constantly making deposits and withdrawals from the bank. All the time. We're pretty much set after about age 30. And after age 30, we start making more withdrawals from our retirement, from our bones, than we're making deposits. Now, there's some things that we can do to make sure that we're making more deposits: proper diet, weight-bearing exercise, strength training, and things of that nature. Swimming isn't going to do it. Cycling isn't going to do it. Hours of cardio isn't necessarily going to do it. You're going to have a lot of diminishing returns there. Strength training is the number one thing, and proper nutrition. Genetics plays a role. If your mom, grandma, sister had osteoporosis, puts you at greater risk for having it yourself. So you really need to take measures and make sure we're getting screened for that. Anyways, so after a hip fracture, men are actually their risk for dying within the first 1 to 5 years after hip fracture is much higher than it is for women, and it's depression related because you lose your mobility. You can't, like, very few people walk away from that. Very few people walk away from that. We're getting really good with surgery. Like, the surgeons that I worked with were freaking amazing, and we would get people up walking the next day if we could. Sometimes it just wasn't going to happen for them. But your risk of dying after a hip fracture, it like doubles your risk of dying the next year. So it's really significant. And this is what gets people when they get older. It's not old age, it's these other things that can happen. So if we can decrease osteoporosis risk by 50 to 70%, for a drug to be called good, to be like efficacious, it only has to work by 10%. That's not very much, right? 10%. That's like FDA approved. Are you serious right now? Yeah, for sure. So HRT, huge. Transdermal estrogen has no increased risk for stroke versus oral estrogen, 1.3 times risk, which is still very minimal to none. Okay. And very effective. There's cognitive benefits, 40% reduction in Alzheimer's risk when started early in menopause, which is huge. Did you know that you have estrogen receptors in your brain? Yeah, it's all over your body from head to toe, in your bones, in your heart, in your brain. We have estrogen receptors everywhere. So it makes sense that we're having all of these other issues like the brain fog and the fatigue and the mood changes. It makes sense. I hope that gives you reassurance. You're like, I'm not crazy. I'm not losing my mind. My hormones are changing, and there's things we can do about it. We got you. Okay. Next question. How effective is HRT for different symptoms? So let's talk about it. So, hot flashes, hormone replacement therapy, HRT. Hot flashes, we see an 85 to 90% improvement. That's wild. That's significant. Once again, 10% is enough for us to say that a drug is working. It's not even for everybody, right? Sleep quality. Improves sleep quality by 70 to 80%. How many women in perimenopause cannot sleep? Waking up in the middle of the night and can't get back to sleep? I have so many of those patients. They come to me. When we work on these things, it's usually multifactorial, meaning there's multiple things that we need to work on, but we can definitely improve that. It's huge. Mood and anxiety, 60 to 75% improvement in mood and anxiety symptoms for women who take hormone replacement therapy. Huge, huge. You can see how impactful this is. Brain fog. Oh my gosh. If anyone has ever suffered from brain fog, I have absolutely had that before. It is debilitating. Like you feel like you're just walking through this really dense fog and you just cannot find anything. It's awful. I get it. Brain fog improvements 65 to 75% for women who are taking hormone replacement therapy. That's a lot. That's significant. Sexual function. This is a big one. This is something that I definitely talk to my patients about is their libido. Checking over here, seeing if there's any comments. Guys, drop your questions in the comments. If you have any questions for me, I'm going through the most common questions, but if you have any questions that aren't being answered or you just have questions about perimenopause and menopause, drop them in the comments. So sexual function, we're talking about low libido. We're talking about that GSM, the genitourinary syndrome that can happen, that does happen for every woman that goes through perimenopause and menopause. Because we have estrogen receptors down there, we have testosterone receptors down there. And those will all contribute to having a lower libido, having dryness, the tissue gets frail, and things actually move, which is crazy. It's not just like if you had a baby and you have some urinary, issues. Women who've never had a kid or spit out a kid down there can have issues. And it's because of the change in these sex hormones, in the estrogen and testosterone and progesterone too. So when we treat these, and if you want to, I've got another video that actually has like over 1,000 views on it. I talk about how we need to do both concurrent therapies, systemic estrogen therapy, plus vaginal topical estrogen therapy, because they do not cross over. They do not cross over, guys. If you are on a topical estrogen or even oral estrogen, it's not getting to those tissues in the vagina, in the bladder. Your bladder is part of that whole system and also has estrogen receptors in it. It's not getting there. So that's why you're still symptomatic there. And you gotta be your own advocate here, okay? Because there's a lot of providers that don't know this. And I had to fight with an insurance company, and hopefully we win. Of course, I haven't heard back yet because that process, don't get me started on insurance. They denied my patient coverage for her topical estrogen because she was taking, they denied coverage for, because she was already on topical estrogen on a patch. They denied her insurance coverage of her vaginal estrogen, which was treating a different set of symptoms and different issues and different delivery route. It's not the same thing. It's not the same thing. These treat two different things. They absolutely belong together. Vaginal estrogen does not go systemic. It doesn't. Women who have had breast cancer, even if it was estrogen positive, can be, in collaboration with the healthcare team that's monitoring you, can absolutely take vaginal topical estrogen to treat those symptoms. Decreases the risk of UTIs. Sepsis from urinary tract infections is a thing. People can die from this. Women have increased risk of death from a UTI. Stupid. And all we have to do is just give them vaginal estrogen. It should be over the counter. We're going to go to the White House and we're going to advocate for that. Vaginal estrogen should be over the counter. We'll see. All right, joint pain. So one of the more common things that we see, or not necessarily common, but one of the symptoms that we see is frozen shoulder. It's adhesive capsulitis is the medical term for it, but frozen shoulder risk really increases through perimenopause and menopause. When we put them on hormone replacement, wow, it is amazing how the tissues and everything can get really stiff. And again, it's estrogen. Who would have thought? Estrogen is everywhere. Okay. It's not just in your uterus. Okay. It decreases joint pain by 50 to 60% and things such as frozen shoulder, but also could be in your knees, could be in your wrists, could be in your ankles, like could be in a myriad of different places. So these aren't just numbers. They represent real women getting their lives back. In my practice, I see these improvements consistently when we optimize the right hormones for each individual. And each woman is different. Okay. So we have to work with that. And that is why what I do is so specialized, because every woman is different and it takes some time to get really into the depths of things and make sure that we're optimizing her properly. All right. Where are we at for time, guys? All right. We're doing good. Okay. Let me know in the comments if you have any questions. If this is helpful, smash that heart button. I appreciate you guys for being here. I really do. Thank you so much. All right, let's do one more question before we go. Why is it so hard to lose weight during perimenopause? We get that. What do they call it? The menopause? Rude, by the way. Super rude. We get a little bit more belly fat. So even if your weight doesn't necessarily change, you might notice a little bit more fat accumulating around the belly. Women gain an average of 5 to 8 pounds during the menopause transition. Some women gain more than that. And there are lifestyle factors going into that. There's that big debate back and forth. I've seen some fitness trainers online, fitness influencers, if you will, and they're saying, oh, it's just diet and exercise. Okay. That's always a factor. I will give you that. Absolutely. But those hormonal changes make a big difference. And then add on top of that, these women aren't sleeping. Okay. They're exhausted. Their hormones are changing. Their mood sucks. They have more anxiety. And you're going to tell them you just need to exercise more and eat less? Are you for real right now? No. We need to, again, dig deeper, find out what's going on, help her to feel better so she can make those choices and actually, get the exercise in and do the meal prep and eat the healthier foods. Yes, that's important. Absolutely. It is the basis of everything that I do, but there is a little bit more to it. Okay. A little bit more nuance. So do not just disregard her like that. It's rude. Metabolism slows by 2 to 5% per decade after age 30. There's a lot of things that are contributing to that. Like this next one, muscle mass decreases by 3 to 8% per decade after age 30. Part of this is the fact that we are sedentary. I'm sitting here in a chair right now talking to you guys. I get it. We're more sedentary than we've ever been. We do need to move more. Convenience foods. Again, we're also so busy. That's the crazy thing. Like, we're more sedentary, but we're more busy than ever. And so those convenience foods that are really high in calories, really high in salt, really high in preservatives, they're not good for us. But God, we're so busy. Like, I don't have time to meal prep. I don't have time to eat healthy. You do, by the way, because you're the most important thing. Okay. So never forget that. And we just need to reassess our priorities and what we do in our lives. And I'm with you there. Trust me. I fall off the wagon and I start, down that road. I have pizza on the weekends because we're tired and we've been working all day. I've done it. But also, I recognize the fact that I feel so much better when I do take care of myself. And I am the priority. I can't show up and be my best version of myself for you guys, for my family, for my patients, if I'm not putting me first. So put you first. Okay. So weight training, huge, 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 because that muscle mass decrease, yes, some of it is aging, but the rest of that is because we're not using our bodies like we used to. We're not out on the playground like we were when kids, running around playing sports when we were younger. Who here played sports in high school and then never played them again? Right? I did play a little bit of rec ball, but yeah, after high school, you go off, you go to college, or you do this or whatever, and it kind of falls off, guys. And then when you hit your 30s, you start hurting yourself and you're like, I'm not doing this anymore. Seems like a bad idea, right? But it's so important. We just need to make adjustments and do exercise that's appropriate for us and where we are, okay? Insulin sensitivity decreases by 20 to 30% during perimenopause. 20 to 30% insulin sensitivity decreases. That increases your risk for type 2 diabetes and metabolic syndrome. Again, estrogen. Who knew? Estrogen is part of that process. Estrogen actually helps us to improve our insulin sensitivity. So as we lose our estrogen, we're going to start losing that insulin sensitivity and increasing our risk for type 2 diabetes and metabolic disease. That will also cause that belly fat gain. Okay. Cortisol levels increase by 20% during the menopause transition. Cortisol, high stress, all the time. Never get a break. That will increase your body. Will start putting that belly fat in there because when stress is high, the body goes, okay, we're going to need quick energy and we need to conserve energy. So it's actually going to put that weight right here where it's nice and accessible for your body, but not for you, because then your jeans don't fit right anymore, right? So yeah, cortisol levels increase by 20% during the menopause transition. And then things we do that aren't recoverative, if we're doing fasted exercise, we're doing a lot of cardio, we're not sleeping because we're having hot flashes, all of this stuff adds up and it makes things so much worse. So we need to just come back down, get full functional labs, work with a provider, and get yourself on a plan that will actually help you with that. All right, let me do one more because I just saw some new people come in. Hi, guys. Thank you so much for being here. Smash that heart button if this is at all helpful for you. And let me know if you have any questions about perimenopause or menopause. Put them in the comments. I'm checking the comments, checking the comments. Thank you for the hearts. Hi, Betty. How are you? So good to see you, my friend. All right. There is just one more thing. It's not even on my list, but I'm going to talk about it anyhow. So another question that I get is, do women need testosterone? Oh, good. I'm glad you're well. Thank you, Betty. Do women need testosterone? Yes. Testosterone is a human hormone, not just a man hormone. And we actually have more testosterone, ladies. We have more testosterone in our bodies than we do estrogen. Yeah. Nobody told us that, but it's true. We just have significantly less testosterone than men do, right? I know, Betty. It's crazy. So what do you think happens to us when our testosterone levels start to decline during perimenopause? Do we just don't notice? We don't have any, we're fine? No, we're not fine. We are not fine at all. So this is often the missing link. I'll get a woman who, like, we've got everything nailed down. We have put her on estrogen because she needed it. We put her on progesterone to protect her uterus and also because she wasn't sleeping very well. So taking oral micronized progesterone at night can really help with that. Calming effect helps with the sleep, helps to keep her asleep. And doing all the other things, correcting her nutritional imbalances. Maybe her vitamin D was low, which will, by the way, cause your sex hormones to be low as well. No one told you that either, right? fixing her diet. She was eating food that was making her inflamed. And that's really hard to fight when you're constantly putting more inflammatory foods in your system. 70% of your immune system is in your gut. Okay. So when we're constantly irritating that, guess what? We're increasing our risk for autoimmune disease, which we already have an increased risk as we're going through perimenopause. Hashimoto's, thyroiditis, low thyroid function is one of the most common things we see with thyroid imbalances going through perimenopause. Don't want any of that, right? So now I lost my train of thought. So testosterone is the one missing link that we can have. So we've done everything else. Thank you, buddy. Low T. So we've done everything else and we've corrected all the other imbalances. And I'm trying to look at both screens here because I'm live on multiple channels. So I appreciate you all that are here. I really appreciate you. You have no idea. Means a lot to me. And I really want to make sure that I'm helping you guys to understand what this is all about. So low testosterone was the missing link. Still had low libido, still had low muscle mass, still had low energy, despite optimizing everything else. Maybe we tried DHEA because that's what the guidelines say to do. We finally were like, you know what? We're going to do this. Or maybe we go a little bit sooner because her testosterone is so low. We know she's symptomatic. We put her on topical testosterone. She takes it once a day. She puts it on her thigh and just rubs it in at night. Makes a world of difference. That last piece finally falls into place and she's finally feeling better, finally feeling like herself again. It makes a huge difference. So all of these things are playing together, guys. Low progesterone, number one. Low and then high and then low and then high again and then low, finally, just forever, estrogen. And decreasing levels of testosterone. Those are the major ones. Those are the major changes that we go through. Changes in your adrenal function, changes in your thyroid function, changes in your gut because estrogen receptors are in the gut and it influences what's called your gut microbiome or the estrobolome. So if you're noticing you have more food sensitivities than you used to, you're not imagining things. That's true. And that's because your gut microbiome is changing as you're losing your estrogen. Okay. So we need to pay attention to all of these things. It makes a huge difference. So I hope that helped. And if there's any questions, and if you guys rewatching the live over on Facebook or YouTube have any questions, you guys over on TikTok, if you would give us a follow. Also, if you go follow us over on Instagram at Anti-Gravity Wellness, we can finally get to 1,000 people and I can go live there again because right now we can't go live because we don't have 1,000 followers over there yet. But we're rocking it over on TikTok. TikTok, I love you guys. I love you guys so much. TikTok is awesome. And Facebook, love you guys. YouTube, love you guys. Love you all. Thank you so much for joining me today. Next week, I am going to be speaking at the Women in Business Conference September 23rd on a Tuesday. And it is, you have to pay to get into it. It's over in Kennewick, Washington with the Tri-City Chamber of Commerce. And I am one of their guest speakers this year. I'm so excited. We're going to talk about hormones and hustle. And how that is impacting women in the boardroom and what we can do about it, because it's, again, this is something that's not talked about, least of all in the workspace. And it's very important because women in our 40s, we are coming into our power. Okay. But we don't feel like it. We're getting just bulldozed by all these hormonal changes. We don't know what's going on. So we're going to talk about it, what we can do about it, and how to start that conversation in the workspace to make sure that women know that you're not alone and you absolutely should be, kind of accommodated basically to be the best version of you. And we're not men, we're not small men. Okay. So we can't function that way. We need to function within our own power. And we are very, very powerful. We're very intelligent. We make a huge contribution and we should be able to continue that. So I'm excited for that. All right, guys, thank you so much for joining me today. And it's Thursday. I don't know if I'll be on tomorrow. I'm probably going to be actually working in my shisha. Look at this. Yes, we have work to do. Okay. There's a lot of work to do, but it's looking really pretty. Look at that. I love the background. All right, guys, thank you so much for joining me and I will catch you on the next one. Bye. Bye, everyone.